Okay. Good evening, everybody. And
Good evening, sir.
let's start ball rolling. And today we're going to discuss on to arthritis into foot and ankle. And we will first start with subtalar arthritis and how do we do subtalar arthrodesis. Then comes ankle, and then uh, we'll discuss triple arthrodesis. So that's also one of the common uh, type of fusions we do. So we all know that any arthritis, we will first try with activity modification, NSAIDs, sometimes intra-articular steroids, bracing, weight reduction. And if it doesn't respond, then the final option would be either arthrodesis or arthroplasty. So far as subtalar joint is concerned, there is no arthroplasty, it is subtalar arthrodesis. For triple arthrodesis, again, you have a fusion only for the hindfoot joints. And for ankle, we have already discussed ankle salvage by osteotomy. And today we're going to discuss ankle arthrodesis. So the one of the most commonly done arthrodesis in foot and ankle is subtalar arthrodesis. So I feel that all the general and trauma orthopedic surgeon must know subtalar arthrodesis by heart because it's easy, it's easily accessible, and is one of the most common, or if I say my most commonly done surgery is subtalar fusion. So we're going to talk about surgical anatomy of subtalar joint, indications and contraindications of subtalar joint arthrodesis, clinically how do you diagnose it, conservative management, types and technique of subtalar arthrodesis, and outcomes after subtalar arthrodesis, and summary. So we know that the subtalar joint has three facets and three joints: anterior, middle, and posterior. When we are talking about subtalar joint arthrodesis or subtalar joint arthritis, we are mainly talking about the posterior facet, which is the largest facet, which is the one which articulates with talus posterior facet. And that is where we are all, unless proved otherwise, when we talk about subtalar joint arthritis, we talk about posterior facet arthritis. It is only when we are dealing with the post-traumatic arthritis of subtalar joint, like post-calcaneal malunion subtalar arthritis, we talk about anterior and middle facet, and we also add arthrodesis of anterior as well as middle subtalar joint. When we are talking about coalition, so congenital talocalcaneal fusion, it is mainly of the middle facet. There we talk about the middle facet. So by and large, we are talking about the posterior facet arthritis. Now, indications for subtalar arthrodesis are primary osteoarthritis. Yes, you do have many patients with subtalar synovitis, which ultimately goes into subtalar arthritis. These cases mainly are bilateral in nature. Post-traumatic is one of the very common. Calcaneal fracture resulting into subtalar arthritis, talus fracture, dislocations, instability, they all can result into subtalar arthritis. Inflammatory arthritis in form of rheumatoid arthritis, gout, psoriatic arthritis are also another type of arthritis which can affect subtalar joint. And posterior tibial tendon disorders also give rise to subtalar joint arthritis. Tarsal coalition, long-standing, would give rise to subtalar arthritis. Some neuromuscular disorders like Charcot-Marie-Tooth disorders, poliomyelitis, CP can give rise to arthritis of subtalar joint. Post-septic arthritis is also common. Nerve injury would lead to instability and arthritis. And if you have multiple joints involved, like polyarthritis, then also it can be involved. So then comes your, okay, uh, clinical diagnosis. Typical complaint in the history would be difficulty in walking or running or climbing or doing activities on an uneven surface. This is the first and foremost hallmark complaint of subtalar joint arthritis. Patient will have lateral ankle pain. Patient will have pain which is localized to sinus tarsi, specifically on inversion and eversion. Patient also complains of pain and instability on going down the stairs. This is again hallmark complaint. Later on, patient will have pain, difficulty in climbing as well as going down the stairs. Clinically, patient has got antalgic gait, swelling and tenderness over sinus tarsi, and sometimes in an advanced case, patient will have a horseshoe-shaped swelling all across the subtalar joint. This painful inversion and eversion, limited range of subtalar joint movements. Sometimes you have tarsal coalition, then there won't be any motion at all. And late cases would have tightness of gastrosolius. And if you're not sure, you can put in a diagnostic local anesthetic injection into the joint and it will confirm the diagnosis. This is about the clinical diagnosis. Radio diagnosis, you take standing AP, lateral and oblique views of foot, AP, lateral, and mortise view of the ankle. And what do you see? You see osteophytes, joint space narrowing, cyst formation, and subchondral sclerosis. Hindfoot alignment view, or the view which is called as Salzman view, is going to tell you the axis of the tibia versus talus versus calcaneus. And obviously, you also take axial views of both the heels. Broaden views, as I earlier mentioned to you, I like to monitor arthritis of the subtalar joint or arthrodesis of subtalar joint or progression of subtalar disease by 10, 20, 30, and 40 degree of Broaden's view. Canal and Kelly's view, if it is associated with a talar fracture, you may like to get it. But it is the CT scan which is also going to give you a D information. Now, what do you see in a X-ray or the CT scan? You see loss of calcaneal height in cases where you have post-calcaneal fracture subtalar arthritis, like here. And we have said so many cases where we had decreased talar declination angle. Loss of arch, flat foot, RA can also give you the diagnosis. Computed tomography will tell you about the extent of arthrosis, the kind of deformity, and if there is coalition, you can identify the coalition with CT scan. And MRI is going to help you in diagnosis of fibrous coalition leading to subtalar arthritis. So I don't think that the diagnosis of subtalar arthritis is very difficult. But the most important thing where I want to point out everybody's attention is many cases they have posterior osteophytes and they have elongated osteoporosis of talus. These patients do develop posterior subtalar joint arthritis. And if you end up doing only excision of the posterior elongated process of talus, patient would slowly and steadily progress into complete subtalar joint arthritis. So if you have a case of posterior process of talus, TDAS process, which is enlarged, you make sure with CT scan that there is no peripheral or posterior arthritis of the subtalar joint. If it is so, you just do the posterior process talus excision and inform your patient that progressively over 5 years, 7 years, you're going to develop subtalar joint arthritis and you might require second surgery. If you don't inform that, patient once comes back after 2 years with subtalar arthritis, patient is going to blame you. So that is only important point. Conservative management would be in form of activity modification, weight reduction, some kind of bracings, analgesics, NSAIDs, insoles, ankle foot orthosis, physiotherapy, and very rarely intra-articular corticosteroid injections to prolong the surgical intervention. Essentially, patient ends up into surgery, and surgery is in form of uh, arthrodesis of subtalar joint. Your goal for the surgery is painless, stable plantigrade foot with hind foot in 5 to 10 degree of balance. So every joint for a fusion has an essential position. So for subtalar joint arthrodesis, the position is 5 to 10 degree of valgus. No joint would ever, either ankle or subtalar joint, would ever tolerate varus. So 5 to 10 degree of valgus is for subtalar joint. 0 degree of dorsi to plantar flexion for ankle, slight external rotation for ankle, and no inversion, eversion is accepted, or no varus valgus is accepted for ankle. So it is neutral to varus valgus. It is 0 degree of dorsiflexion to plantar flexion and slight external rotation, which is the functional position for ankle fusion. Most important, talus has under the tibia into the mortise is what you want to do. And you want to correct the talocalcaneal angle. You also need to correct the deformity whenever you're doing fusion. You don't want to fuse in situ. Now, what is your surgical checklist? Number one, you look at the alignment of subtalar joint. If it is in varus, you have to correct it. If it is in gross valgus, you also need to correct it. If it is in gross varus, not correctable, you might have to add osteotomy in form of Dwyer's osteotomy. If it is very bad valgus, you may have to add medial calcaneal slide osteotomy over and above subtalar fusion. You need to check the motion of adjacent joints. You need to check joints proximal to the foot, joints distal to the subtalar joint, status of the soft tissue envelope, and accordingly you need to plan your incision. Look for the neurovascular status. Look for information to the patient and open discussion and written consent of your patient. Principle of any fusion is well-planned incision, correction of deformity, careful soft tissue handling, meticulous joint preparation means first, removal of the cartilage, second, drilling, third, osteotomy singling, fourth, if required, bone grafting. Broad cancellous bleeding surfaces is the aim for fusion. Rigid fixation with compression and precise positioning and alignment of the arthrodesis all formulates the principle of arthrodesis. Now, what all are the type of subtalar arthrodesis? Yes, open subtalar arthrodesis, arthroscopic subtalar arthrodesis, and a distraction subtalar arthrodesis, which we have shown in two cases where we had to put in a iliac crest bone graft to increase the height. Now, what are the approach? Sinus tarsi approach, posterior approach, and extensile lateral approach. These three are the approach. Sinus tarsi approach, if the subtalar joint arthritis is not having any deformity and it is in well-maintained position, you may put in a small sinus tarsi approach, clean out everything and do subtalar fusion. If subtalar arthritis you require in form of distraction subtalar arthritis, then the posterior approach is preferred, through which you can do the curettage, you can do the clearance of the joint and put in a posterior bone graft through the iliac crest. An extensile lateral approach is one where you, following a calcaneus fracture, you want to do primary subtalar arthrodesis, you use the extensile lateral approach. Now, for an open surgery, you put your patient into lateral position with a tourniquet inflated, and a sinus tarsi approach, a small approach from the tip of the fibula to the base of fourth metatarsal is done. You need to take care of superficial peroneal nerve, which lies dorsal to the incision. You need to take care of peroneum, which lies ventral or below the incision. You raise the extensor digitorum brevis muscle, and then you reach into the sinus tarsi, clear it, distract it, and curate out the cartilage, do the joint preparation, and then put in your bone graft if you need and fuse the joint. So cartilage scraping, drilling of subchondral bone, fist scaling of the bone within osteotomy, good apposition, temporary fixation, image check, definitive fixation, and closure. These are the steps of open subtalar arthrodesis. For a subtalar arthrodesis, you put in two screws. The screws that are passed through the non-weight bearing area of the calcaneus. And from non-weight bearing area of the calcaneus, the first screw will go from lateral aspect of the calcaneus to the body of the talus. Why lateral? Because this screw maintains the valgus of the heel. So that's why we want to put the lateral screw first. And this is partially threaded screw. The next screw is a medial screw, which goes from the calcaneus body, non-weight bearing portion, to the neck of the talus. Again, that's partially threaded, but that is put in second because you want to first secure your position of hindfoot valgus by putting a lateral screw first. And there is a screw described by Roger Mann, which is called as Roger Mann screw, which is anterior screw, which goes from the calcaneus to the neck of the talus. This screw is preferred into post-traumatic and revision arthrodesis. And this is the screw which is fixing and fusing anterior and middle subtalar facets. Now, these are various examples of subtalar fusion cases, but distraction is done into the cases where you have a kind of situation where your talus is lying into a dorsiflex position into the mortise. You want to restore the talar declination angle. For that, you do distraction subtalar fusion. You can use extensile lateral approach for distraction. Sometimes if you distract it a lot, there could be issue of the skin closure. So that you have to be watchful. Most often than not, we like to use posterior approach where your skin issues, even if you lengthen the calcaneus, even if you lengthen the subtalar joint, distract the subtalar joint, the issue of the closure will not come if it is a posterior vertical incisor. You expose the joint, you prepare the joint, and you put in a lamina spreader or intermittent distractor to jack up the talus and then accordingly decide the size of the graft you need. This is the graft put in, and then put in a fully threaded screw which would maintain the position of the distraction. Fusion of all three joints with an use of anterior screw is what is required for a distraction subtalar fusion. Okay, before I go on to cases, there is a question. Roger Mann screw from medial side, lateral side. No, this is from the lateral side. You are working in a position where patient is lying into lateral decubitus position with the lateral side in front of you. So you put in a screw from the lateral side of the anterior aspect of the talus, of the calcaneus, which is going into the head and neck of the talus. So that is how it is a lateral screw, lateral to medial. Male of 60 years, 16 months post-trauma, had a pain and disability. You can see malunited fracture calcaneus, where there already is varus. And this is the another view of this patient. And many times for a distraction subtalar fusion, you may take bone graft from the posterolateral angle of the calcaneus instead of going to the iliac crest, and you can put in the bone graft strategically here to increase the length of the or to increase the talocalcaneal angle. So this is where the is the place from which you can take the bone graft and you put in this bone graft into the space between subtalar joint, and you can distract the subtalar joint. So now you can see that the talar declination angle is restored. So, okay, why is that we are not seeing? I will just draw. So this angle is now 120, which is the aim of the surgery. And the graft has been taken from that place. Okay, there is arthroscopic subtalar fusion described, which is technically demanding. There are lateral portals and there are posterior portals. And you could take both. 2.7 mm 30 degree scope is what is being used. You need to put in a traction between talus and calcaneus, and you have an anterolateral or posterolateral portal, or accessory anterolateral and accessory posterolateral portal, and a central portal when you're doing it into the lateral position. In a posterior position, you have a posterolateral and posteromedial portal. And in a posterior arthroscopy, patient is lying into the prone position. The portals are just by the side of tendo Achilles, and you may not need distraction. You can better control the coronal plane vision. There are no injuries to sinus tarsi content, but if you are not watchful, you may injure neurovasculars with this approach. So injury to the tendon and vascular injuries are common if you are misfiring your entry and your surgical approach. For lateral arthroscopy, it is the lateral position which is preferred. You put in an anterolateral and posterolateral portal, sometimes central portal. In the similar way, you prepare the joint, and same type of the fixation is what is being done. Arthroscopic arthrodesis has limitation in form of the large deformities cannot be tackled, bone loss cannot be tackled. Previous non-union or malunion would require destruction in bone grafting that cannot be done arthroscopically, and there is difficulty of accessing the subtalar joint, and there is a learning curve for this arthroscopic technique. By and large, majority of the people do open subtalar arthrodesis. Outcomes are good. Reported outcomes are to more than 90%. Either you do open or arthroscopic arthrodesis. Infection, non-union, malalignment are the problems, and that should be dealt with accordingly. Symptomatic hardware, RSD, these are another complication. So in short, high fusion rates and functional improvement have been reported after both open as well as arthroscopic subtalar arthrodesis. Arthroscopic fusion is shown to produce better results, shorter hospital stays, fewer complications, but has a learning curve. Strong evidence to prove efficacy of one over other is still required. So that was about this subtalar arthritis and subtalar fusion. Uh, any question regarding subtalar fusion, distraction subtalar fusion? For the distraction subtalar fusion, in a long-standing case, you would need primarily either gastrocnemius lengthening. If the case has got more shortening to be corrected, you may need open tendo Achilles release.
Sir, can I ask a question?
Please.
Sir, actually, I've done a few subtalar fusions, and the main problem which I have faced is like when the patient is supine, to getting the orientation of the subtalar joint and getting the wires in the right position. I'm talking about the cases in which the deformity is not such, it's just primary OA is there, and you take the sinus tarsi approach, we prepare everything, but getting the wires at the right position is right, like it takes a toll on me. Like it happened to me twice or thrice that wires were going haywire. How to get them right, sir?
Yeah. So, while I got trained into doing subtalar fusion in a supine position. And typically, when you're putting wire, you have to lift up your foot and you need to see axial imaging. And that's really difficult. And you're relying on palpating the heel between your two fingers and thumb. That gives you an idea that, okay, your wire is not going medial or lateral. Sometimes people, while doing this kind of a fusion, like to put in screws from top to bottom. But when you put in screw from anterior aspect of the ankle to the heel into calcaneus, you need to be very, very watchful not to injure important tendons and neurovasculars. You also should be watchful not to pass screws through the articular surface of ankle. So these are the difficulties. And in 2018, we had I organized Indian Foot and Ankle Society's annual meeting in Baroda. And we had demonstration of surgeries as our CME on day one. And then One of the international faculty, immediate past president of American Orthopaedic Foot and Ankle Society, he pushed in screws into the subtalar joint through this same kind of an supine position, and he passed in two screws from the heel right up. And then we suggested that, sir, would you like to have look at the image? He said, no, because I'm able to palpate the screws between my hands, my finger and thumb. So that patient had the one screw going on absolutely medially and going out medially and was impinging the neurovascular. So at the end of the day, when everything got over, this patient had terrible pain, and I had to revise subtalar fusion in the same night. On the same night, I had to remove that screw and I had to revise the subtalar fusion. So this is the issue. You need to see AP, ankle, you need to see lateral ankle with foot and axial image. Twice or thrice what I have done, that I have pushed the screws into the anterolateral gutter of the ankle. So you must see AP ankle, making sure that the position of your screw in the talus is precise, is not going haywire. So if you push screw into anterolateral gutter or outside, then there would be issue. So look at the AP ankle, look at the lateral ankle with foot, look at the axial image. This three imaging would be helping you. Now, to really answer your question, Dr. Prabhu, I have stopped way back. I have stopped giving uh, supine position for subtalar fusion. I am using a lateral position for subtalar fusion. It really helps me. Number one, if I want to correct varus or valgus, I use a bump. So a bump is pulled out if I want to give valgus. So that is what we know we need to. So with one hand, assistant pushes the lower third of the tibia down and bump is over the heel. So automatically heel and the subtalar joint is brought into the valgus and you're able to pass your screws like that. Only thing, your AP imaging will show you lateral, and when you turn CM into lateral, you will see the axial image. So that is how I do it. So I always do it in a lateral position with a bump underneath the ankle. And you try this and you will be really surprised that how easy it is. More so when you're doing revisions, you need to reach out to the middle anterior subtalar joint. It's very easy when you use your lateral approach. And we are doing calcaneus, we're doing all other, many of such surgeries in a lateral position. So for me, if I'm doing triple arthrodesis, I'll first keep my patient into lateral position, I'll fuse, I'll prepare subtalar and calcaneocubital joint through sinus tarsi approach, and then flip over the patient and do the preparation of talonavicular joint. So lateral position is a very versatile position for subtalar fusion. That is what is my personal feeling.
Thank you, sir. Point well taken.
Okay. Yeah. So now we will be going ahead with the ankle fusion. So ankle arthrodesis, uh, typically we do ankle fusion by either anterior approach, which is between extensor hallucis longus and extensor digitorum longus. This is the same approach through which you do ankle arthrodesis and ankle replacement. So that's an anterior approach. By and large, the most commonly used approach is a lateral transfibular approach, where through the lateral approach, you do excise the lower 2.5 centimeter of fibula, reflect it down and prepare your ankle and do your ankle preparation and ankle fusion. So So there are two approaches, anterior and lateral approach for ankle fusion. The position is 0 degree of dorsiflexion, plantar flexion, 0 degree of varus valgus, and just few degree of 5 to 10 degree of external rotation to increase the liver arm. Whenever you are doing ankle fusion, you are trying to push talus posteriorly, and you're trying to make sure that the dome of the talus comes directly underneath the ankle. So here is a talk which I was asked to give at last year's Malaysian Orthopaedic Association's annual meeting. And the talk was in form of with the title being the treatment potential and limitations of ankle arthrodesis. So this is a talk with voiceover. So once I start the slideshow, you will listen to my voice and the slides would run like that. Okay. So if you have any question, stop me in between. I will stop the talk and will answer the question. Okay. And if you don't listen to sound, then also let me know. Hello, everyone. I am Dr. Rajiv Shah from India, and I'm going to talk on to ankle arthrodesis,
Are
treatment
you all listening to the
potentials,
sound?
and limitations.
Yes, sir.
And this is going to be the learning objective and flow of my talk. So, ankle arthritis can be due to multiple etiologies like post-traumatic, primary osteoarthritis, inflammatory, infectious, neuropathic, synovial disorder, hematological problems, congenital problems, neoplastic problem in cases with severe instability. But trauma is the most common etiology. It can be treated with multiple modalities like ciliectomy, joint debridement, distraction arthroplasty, joint preserving osteotomies, allograft replacement, ankle fusion, and total ankle replacement. But I would say ankle arthrodesis is the gold standard. Why is that it is a gold standard? Because ankle arthrodesis is applicable to every possible etiology of ankle arthritis. Let's go ahead with the indications of ankle arthrodesis. Any age, moderate to severe ankle arthritis could be indication for ankle fusion. Male of 32 was treated for fracture pots like this. At the end of a year, this ended up like this, and then it has to be treated with ankle arthrodesis. Another fresh ankle fracture with a male of 36 years was treated like this. At the end of 6 months, another surgeon revised it and did not address the deltoid issues, and this ended up into ankle arthritis, and at the end of 2 years had to be treated with ankle arthrodesis. Female of 52 years had a primary ankle osteoarthritis, though it is rare, it was there in this female, and she had to be treated with ankle fusion where a plate as well as screws were used. Ankle arthritis with bone loss would be a pure indication for ankle arthrodesis. Such defects requires to be filled with ankle and treated with ankle arthrodesis. Ankle arthritis, when is there deformity like this, would require ankle arthrodesis. Inflammatory ankle arthritis, like in this lady, female of 38, who had a polyarticular rheumatoid arthritis, was treated with ankle fusion where the screws were spanned across the stiff subtalar joint. Bilateral ankle arthritis in a male of 43, though it is little relative contraindication, this patient was treated with a plate on one side and screw on other side with ankle fusion. Septic ankle arthritis, like in this patient, a young adult with infection after compound injury with a very bad skin condition, he was treated. This was his skin condition, and he was treated with serial debridement, expic support, followed by nail assisted open ankle fusion. So these are the situations where only ankle fusion would work. Case of recurrent ligament laxation It is like this who had twice operated failed kind of a procedure would require ankle fusion. Charcot neuroarthropathy would require ankle arthrodesis. A diabetic female of 62 years had a fall in bathroom, presented to orthopedic surgeon at the end of 3 days walking. And this is how orthopedic surgeon treated this lady. 4 weeks down the line, this fixation started falling apart. Surgeon went in and revised the fixation with a plate and screws, but infection set in, and on one fine day, this is what happened. And then it was a case of infection, Charcot, non-union, lower third fracture, and this could only be managed with ankle arthrodesis, where this was managed with nail-assisted ankle fusion supported with Elizaro apparatus for fracture fixation. There are some great potentials, great extended indications for ankle arthrodesis. Let me take you to them. Complex or neglected trauma, ankle arthrodesis would be a boon. A male of 24 years had a neglected pilon fracture. It was now 6 weeks. What could be done? This patient was treated with antegrade nailing and antegrade nailing assisted ankle fusion. Male of 29 had a bilateral comminuted pilon fracture, bilateral fracture talus and calcaneus, who presented to our center for definitive management at the end of 2 weeks. This was the X-ray picture on the left side. This was the X-ray picture on the right side. I don't then ankle fusion assisted by a nail and went on to heal nicely. Arthritis, when is associated with a fracture, the treatment would be ankle arthrodesis. 45 years old male, 100 kg weight, fresh fracture of medial as well as lateral malleolus with pre-existing ankle arthritis has to be treated with ankle fusion, where the fusion mass also covered the fracture. Arthritis plus non-union, you would require ankle fusion. This male of 21 years had an open grade 3 pilon fracture who got infected, operated thrice, and ultimately was referred to us. When he presented, he had ankle arthritis, non-union of the pilon fracture, and infection was under control. Now, this patient had to be treated with ankle arthrodesis, and a fusion mass was extended higher up to cover up the non-union of the pilon fracture, and bone grafts were added. Poor skin condition means ankle arthrodesis. Such kind of poor skin condition cases cannot be treated with ankle arthroplasty. Ankle arthrodesis would be the only option. Such kind of poor soft tissue envelope would require ankle arthrodesis, and then it would be the skin condition which would dictate your positioning of implant, either a lateral plate or a lateral implant, anterior approach or a posterior approach. Neglected deformities would require ankle arthrodesis. Look at the way this 36 years male, he walks here. 3D printed model of his deformity was created and ankle arthrodesis was done, and this is how the foot came into plantigrade position. Female 25 with progressive deformity of the ankle since childhood. Some surgery was done in childhood, and the way the X-ray looks with quite grotesque, bad deformity, improper weight going onto the ankle. This is the way she walks. Her medial malleolus is about to touch the floor with this kind of bad valgus, and the solution for such patient would only be ankle arthrodesis, which was done in this patient, and patient went on to do good. Another potential of ankle arthrodesis is for avascular necrosis of the talus. Such cases would require ankle fusion, then ankle replacement. Look at this post-talar fracture, AVN plus arthritis with a stainless steel implant had to be treated with transfibular approach, ankle fusion. Certain complex situations are amenable to only ankle arthrodesis. Let me show you cases of some complex case of a complex situation. Female of 67 years had a rheumatoid arthritis, non-healing plantar ulcer of 1 year, and this is how the closer view of the ulcer looked like. This patient on X-ray showed complete dissolution of calcaneus, which was eaten away by the infective organisms. And this was the X-ray picture. She went from pillar to post and was advised amputation. We thought of going ahead into the defect, and then in the second stage we went for a fixation. A plate assisted ankle fusion was done in the second stage, and this lady went on to heal and started walking at the end of 1 year, and limb could be salvaged. If we look at the outcomes of ankle arthrodesis, there are more than 100 studies in literature which are available who have studied about the outcome following ankle fusion. Union rates with modern techniques are to the tune of 85 to 100%, and good to excellent outcomes are seen in more than 85% of the cases. But there are limitations. Limitations of ankle arthrodesis, if we see, there could be operative pitfall, and operative pitfall could be penetration of the hardware into the subtalar joint, which also damages the subtalar joint. It could be a malunion, and malunion could be into equinus position, could be into valgus, could be into varus, and gives rise to lots of problem and requires correction. This is one of my own case where ankle fusion was done into equinus like this and had to be corrected with a supramalleolar osteotomy like this. Non-union rate in various studies is to the tune of 0 to 41% with an average of 10. And the rate is high in the cases with diabetes, smokers, rheumatoids, revisions, and infection. And then there is a dilemma of the treatment if you have an asymptomatic radiographic non-union. Look at this case of mine, male of 63 years who had a bilateral osteoarthritis of ankle. Total ankle replacement is not available in India, and he was treated before 2 years by me with ankle fusion, and he is presently having asymptomatic non-union and is doing all of his activities. Another limitation could be infection. The rate is to the tune of 5%. Various studies have come up with this rate, and then infection is a disaster. Years went in and we did revision ankle fusion with dual plate and bone grafting. The abnormality of the gait has been postulated into various studies where the cadence and the stride length of the gait is decreased, and the never a good normal rate gait returns after ankle fusion. But look at this, one of my patient, a male of 39 who had a compound injury 9 months back, was treated with this kind of fixation and a flap coverage was done, which went on to infection. And then we went in, did the debridement, removed the implant, pushed in antibiotic granules, and external fixation was applied. A flap was also covered afterwards, and this is how he looked in. At surgery 4 we went in, we removed the external fixator, cleaned up everything, and pushed in ankle fusion with the bone graft and a lateral plate which went on to unite. But look at this at the gait of this young man at the end of 4 years after ankle fusion, though he has some compensation in his shoe for his shortening, it hardly is evident whether he has been arthrodized, and if at all he has been arthrodized, what side of ankle is arthrodized. So my level 5 evidence says that younger population, they do very well with ankle arthrodesis. Adjacent joint arthrosis is being studied extensively by various studies, and it is said that at the end of 8 years you have 50% of the cases who have hindfoot degenerative joint disease after ankle arthrodesis, which increases to 100% at the end of 20 years. Reoperation rates are 2 to 3% of subtalar fusion rate at the end of 5 years after ankle fusion is noted. But the reoperation rate gets stabilized while that in the total ankle replacement goes increasing. So if we want to see and go back to the literature of ankle arthrodesis versus ankle arthroplasty, earlier studies said that total ankle replacement is bad vis-a-vis ankle arthrodesis. But the latest studies have started saying that there is a trend towards better results in terms of quality of life, physical and athletic ability after total ankle arthroplasty. But still, long-term follow-up and high-quality studies are required. Some recent studies and the latest study of 2019 showed that revision rate of 16% and survival of implant at the end of 15 years was to the tune of 76% for star total ankle replacement. So to put in a final word, you could do ankle replacement at every age. Deformity and defects is not a problem. Activity level is not a problem. Infection neuropathy is not a problem. But joint movements is not a problem. Bilateral case is a problem for ankle fusion. Previous degenerative fusion is a problem for ankle fusion. Gait is not normal. Degeneration in adjacent joint is possible. But so far as we are concerned, as the implants are not available and we have a lot of complex cases, we enjoy and we love ankle arthrodesis. Thank you very much. Thank you, MOA.
So, this was about ankle fusion. When you do the ankle fusion, either you can use a plate, you can use screws. Typically, the first screw which you use is called a home run screw. This screw goes from posterolateral aspect of tibia to the anterior aspect of the neck of the talus. So from lateral, posterolateral to anteromedial. This screw really pulls talus back over the tibia into the compression. So this has to be the first screw, followed by you can push in screw from medial to lateral, lateral to medial. You can push in anterior to anterior. I mean, there are various configurations you could use. Only thing that these screws must be compression screws. The screws must not cross at the fusion site, and uh, you should be having a broad cancellous surfaces opposed into the position of fusion. So that is what you need to make sure. There are plates available, plate presently which is available is an imported plate by Arthrex. That's a very costly implant. Indian version, I don't think that good Indian version is available. What about implant removal after fusion? You really do not need to remove the implant unless there is some issue. Implants are always kept in. Yeah. If there is an infection, you may have to remove the implants. Otherwise, you don't need to remove them. Postoperative care after ankle fusion, I typically give a Belloni splint or a slab for about 4 to 6 weeks, and then it is followed by gradual toe and forefoot mobilization exercises, isometric strengthening exercises, and weight bearing is not started before you see a good consolidation. The first X-ray is taken at the end of 4 weeks. The next X-ray is taken at the end of 4 weeks.
By 8 weeks, when you see there is consolidation, you may start assisted partial weight bearing, which can then be converted slowly over full weight bearing and activities of daily living. It's about 2.5 months that patient starts all activity of daily living when you treat them with ankle fusion. Uh, there's a question. The question is tips for arthrodesis in infected cases. Now, it's your wisdomful call to go in for single stage or double stage ankle fusion. When you have slightest doubt of, sorry, infection uh, in a patient, you should be going into two-stage ankle fusion. In the first stage, you do debridement, you do curettage, you put in a lot of saline wash, and then you may put in an antibiotic impregnated cement granule and um, put an external fixator. Continue with the culture sensitive antibiotic, specific antibiotics for about 4 weeks, sometimes 6 weeks. Then repeat your serology, repeat your culture, and once everything is stable, then you go for the second stage surgery. In a second stage surgery, again, you might have to end up with some kind of a shortening, but that is acceptable. So, infected case, make sure that infection is quiescent. You may go ahead with single stage. Infection is slighted doubt about the infection being active, go ahead and do two-stage procedure. That is it. So I many times use lower end radius plate, which I band, and I use it for the ankle fusion. Any question, any confusion on to ankle fusion? That typically we were taught that we can use the Chanlis compression type. No way that they are used. When you do transfibular ankle fusion, you may put in fibula back, slice inner half of the fibula, use it as a bone graft, and half of the fibula is put in back over its position, and one screw from fibula to tibia, fibula to talus goes, and this would stabilize uh, fibula with tibia and talus. So there would be three good articulating surface in that case. If the patient is young and you're doing ankle fusion, you may think of using anterior approach, which is little technically difficult. You have, I don't know, I am yawning so much. So from anteriorly, you need to go right back. So that is something sometimes little difficult when you have a lot of adhesions. So if you go transfibular, you are able to reach out to the anterior as well as posterior side of aspect of the ankle joint. Wherein through the anterior approach, it is little difficult to go right deep up to the posterior part of the ankle. So majority of the people would use lateral transfibular approach, but you may use anterior approach also. So we spoke about the position, we spoke about the indication, we spoke about the passage of the screw, we spoke about the post-op care for ankle fusion. Minimal length of the nail. Now you see nail-assisted ankle fusion. I said it is ankle fusion, but in reality it is TTC fusion because you're spanning ankle as well as subtalar joint. So the minimum, the length, the nails, they come in the length of 150, 180 plus 30 is the size of the nail as we go on. So 150, 180, 210, 240, 270, 300, 330. So it depends on the size of the tibia. But the bottom line is that you must cross with your nail beyond isthmus, beyond isthmus. So at least my known nail is shorter than 240. So 240, 26, and 210, 240, 260, something like that is what you are using. If you use a short nail, it would be the tip which is going to be a stress riser, and patient would have fracture there at that level of the tip of the nail. So use a longer nail. That is the message. So anything we have not covered into ankle arthrodesis, that's also one of the surgery which you all can carry out. If you're doing anterior approach, you will have to put in a laminar spreader or intimate distractor to really distract. Sometimes if the tendon is very tight, you may have to release it. Okay, do you prefer straight or lateral entry nail for TTC fusion? See, I already said when we discussed on a video of TTC nail that I use a straight nail. And there's a big controversy in the world whether to use a straight nail or an angled nail. It is said that as long as you can bring your talus underneath the tibia, it really do not matter whether you use a straight nail or you need a curved nail. The issue comes when you have a defect, then you may have to maintain the length of a nail and put in some bone grafts, and it is at that time, or when you have a very gross defect, it is at that time the curved nail gives an issue. Giving a compression to the tibia, to the ankle, to the subtalar joint is not possible with the curved nail. The third disadvantage of the curved nail is you have to use it either in the lateral position or prone position. So that also gives discomfort not only to you, but also to the anesthesiologist. So I am a fan of a straight nail, and with the straight nail, the kind of nail I've designed, we can give compression at ankle, at subtalar joint. So that is what I prefer.
Sir, in case of subtalar fusion, will you do calcaneal cuboid fusion also along with that?
No, no. So now talking to triple fusion, typically in foot and ankle, the change concept says try to salvage as many joints as possible. So triple fusion is never a triple fusion. It is not a fusion of calcaneocuboid, subtalar, and talonavicular joint. Now, most often than not, a fusion of talonavicular and subtalar joint is done. You don't fuse calcaneocuboid joint unless number one, patient has got calcaneocuboid joint symptomatic arthritis. Unless patient has got rheumatoid arthritis, infective arthritis, inflammatory arthritis, then you fuse subtalar calcaneocuboid. Otherwise, the only talonavicular and subtalar joint fusion is done when we talk about triple fusion. Triple fusion means these two joints. This is what is the tune of today in foot and ankle orthopedics. So calcaneocuboid joint only if it is very much symptomatic, only if there is degeneration into calcaneocuboid joint, only if the calcaneocuboid joint is affected through an inflammatory arthritis of the foot and ankle. So the next talk which we are going to talk is onto triple fusion. So what all things you have to take care doing triple fusion. So if we do not have any question onto subtalar fusion, onto ankle fusion, we go ahead onto triple fusion, which is talonavicular, subtalar by and large, plus or minus calcaneocuboid. So let me show you triple arthrodesis. Now this was my recorded talk at Pakistan Orthopaedic Association's annual conference. So I am just playing it. You will listen to the sound, and if you have any question, just stop me in between and we can always discuss. So I am starting a slideshow, and it is a recorded slideshow. Hello, everybody. This is Dr. Rajiv Shah, Chairman of Asia Pacific Foot and Ankle Council, India, talking to you on to triple arthrodesis, what I have learned. Every learning comes very hard. So let me share what have I learned from my failures at triple arthrodesis. Before surgery, check the status of soft tissue. Poor soft tissue like this would mandate change of your surgical plan. You need to check motion of adjacent joint. If the arthritis of the adjacent joint is there, then patellar fusion instead of triple fusion, like in this case, was carried out. Evaluate every deformity. Deformity correction needs to be planned together with the fusion. So planning of correction of every deformity must be done pre-operatively only. Check the status and alignment of the proximal joints because the disease and deformity of the proximal joints would mandate change of plan. So what is first? Is that knee or foot? Obviously one which is more symptomatic, like in this case knee, would require correction first. Before surgery, one needs to check vascular status of the limb. Vascular compromise would be a contraindication for triple fusion. One has to check neurological status of the limb, and if the neuropathy is present, then it would require some different fusion tactics. Like in this case of failure of triple fusion, patellar fusion was done. For a neuropathy, you would need longer, stronger combination fixations and spanning fixations. Your fusion has to have extended immobilization, extended non-weight bearing, and long-term protection. Evaluation of tightness of gastrocnemius is very important. This is done by Silverskoy test. And if the gastrocnemius is tight, you need to do release of aponeurosis of gastrocnemius. And if tendoachilles is tight, then percutaneous triple incision tendoachilles hemisphere resection lengthening can be done. Vascular status of talus must be checked before surgery because if the talus is avascular, the procedure would change. You need to get an MRI and then either you go in for tibiotalo-calcaneal fusion or you go in for total talus replacement for AV and talus. At surgery, the lessons learned are following. Long well-trained incisions, full thickness flaps, meticulous tissue handling. This is a lateral incision for subtalar fusion and calcaneocuboid fusion. That's a medial incision for talonavicular fusion. A deformity like this, when requires multiple incisions, you need to plan the incisions in such a manner that the soft tissue gets healed easily. At surgery, gentle superficial skin incision is followed by hemostat dissection to identify nerves and prevent injury to cutaneous nerves. This is how you prevent injury to saphenous nerve at medial incision and superficial peroneal nerve at lateral incision. Broad cancellous bleeding fusion surface are required. Also, rigid fixation and compression of the fusion surfaces is deemed, like done in this case. Drilling of subchondral bone to increase the vascularity should be done to augment the fusion, and you should be feathering the fusion surfaces with an osteotome to increase the vascularity, like done or shown in this video. Preserve excised bone to be used as a graft with a strategic placement of this bone to correct the deformity. In this case of malunited calcaneus with a subtalar and calcaneocuboid fusion, a graft is strategically placed to correct the deformity. Autologous bone grafting from cancellous surfaces, cancellous areas of calcaneus, lower and tibia, proximal tibia, and iliac crest should be prepared whenever there is a defect or deformity. Fusion alignment should proceed from proximal to distal. So you do correction of midfoot over hindfoot, correct forefoot over midfoot. Fusion cell never done in situ. Correction of deformity is a must. Look at this case. This patient had a non-healing ulcer of many years because of incorrectly done subtalar fusion, which was because of the varus positioning. Deformity correction requires use of special distractors, some soft tissue releases, and both excisions is what you need, and then you need to mobilize the joint and correct the deformity. Compression screws which are used for fusion must not cross at fusion site, and all threads must cross fusion site like shown in this figure. Subtalar joint is fused into 0 to 5 degree of valgus, and talonavicular and calcaneocuboid joints are fused in neutral abduction or adduction of the foot like in this picture. Always put two fingers through both medial as well as lateral approach to confirm your precise talonavicular reduction. At surgery, a small bone is removed from the anterior process of calcaneus to give a resting area for a compression screw which you use for calcaneocuboid fusion. A proximal soft tissue entry is used for calcaneocuboid joint fusion to get the proper trajectory of screws which fix CC joints. Pack maximum amount of bone grafts at quadruple arthrodesis site, and this is the arthrodesis site where anterior process of calcaneus, cuboid, lateral part of navicular and lateral part of head of talus meets each other. Evaluate foot arches. Adjacent flat foot corrective procedures would be mandatory, and evaluate foot position once you do your fusion, because additional procedures might be required to achieve plantigrade position of the foot. This patient with a bad stage 3 flat foot was treated with at surgery fusion of. Look at this case where
No, I think the third and
some quick
just a bit.
examples are deformed
Sorry.
of the foot. This patient with a bad stage 3 flat foot was treated with a deltoid reconstruction followed by subtalar fusion and talonavicular fusion. Likewise, deltoid was reconstructed with a hamstring graft. So you see triple arthrodesis plus deltoid reconstruction. At surgery, fusion of only talonavicular and subtalar joints utilizing a medial approach which is called as medial double procedure can be done. And this is probably today's tune. Look at this case where a medial incision through the medial incision, talonavicular and subtalar fusion was done. Today's tune is to do only fusion of talonavicular and subtalar joint. Calcaneocuboid fusion is added provided a case has a symptomatic calcaneocuboid arthritis or it is a case where there is seronegative arthropathy. Some quick examples are deformity like this, which was posed under CTV correction, was treated with triple fusion. Trauma, bilateral, bad, severe calcaneus fracture with dislocation and involvement of calcaneocuboid, talonavicular, and subtalar joint was treated on the left side with talonavicular plus subtalar fusion, and it was also treated with talonavicular and subtalar fusion on the opposite side. Adult acquire flat foot. Picture like this with such a bad direction through towards the arch. Like this case requires such kind of with correction of the arch. Medial double procedure normally is being done in cases where there is severe foot valgus to prevent soft tissue problems. A medial double approach can be taken in such cases. This was the case of congenital fusions of talonavicular, calcaneocuboid, and talocalcaneal joints with coalescence. This was corrected with subtalar corrective fusion and talonavicular fusion. Pediatric flat foot, if it is bad like this, could also be treated. Now look at the deformity and was treated with talonavicular and subtalar fusion. That's all. Thank you very much. Thank you, Pakistan Orthopaedic Association, and my sincere thanks to Professor Rizwan. Bye.
So there was some loss of voice in between, but this is how pre-surgery, intraoperative and postoperative, you make sure that your fusion procedure would be successful. And there are so many indications where you need to do triple fusion for deformity, for flat foot, for long-standing cavus foot, post-trauma, pediatric flat foot, all these places, there's a role for triple fusion. In a trauma also, there's a role for triple fusion. But not that while I got graduated, I was taught that any problem in foot ankle, you go ahead and do triple fusion. So that is not the notion. Notion is you try to salvage the joint as much as possible. And if you're not able to salvage the joint, then do triple fusion. And not that every case would require triple fusion or pantalar fusion. It would be on the merit of the case that you will take a call whether you want to do triple fusion or double fusion or single joint fusion. And the message is very loud and clear. Try to salvage maximum possible joints. Try to salvage at least essential joints. If not, non-essential joint can be sacrificed. So any question, any confusion, any query onto this common arthrodesis into foot and ankle? Obviously, first metatarsophalangeal fusion is one of the important topic which we are going to discuss in the section of forefoot. We were to go ahead and discuss diabetic foot and Charcot, midfoot, hindfoot, and ankle on this Sunday. But Neeraj Bhai and Ashok Shyam has requested that because these Fridays, Saturday, Thursday, Friday, Saturday, Sunday being days of Vairok, they were requested me not to have any session on those days. So we'll be not having any session on Sunday. Maybe we'll have sessions on Tuesday, Friday, like in the next week. So now we're going to discuss this short topics more of cold orthopedics. We have had discussion of the orthopedic foot and ankle trauma till these dates, and now we'll discuss the cold issues of foot and ankle. Okay, any more question, any suggestion, any comment, or call it a day today? Okay. Chalo. Good night, everybody.
Good night, sir. Thank you so much, sir.
Good. Yeah.
Thanks,
Thank
sir.
you. Bye.
Good night, sir.
Yeah, please. Good night. Good night. Good night. Bye.